I think we can cover most of the, or at least many questions. I have tried to combine some of them, and some questions are in the chat, some others in the Q&A. I will start from a provocative question. Dr. Roy Steiner says, I have noticed that the high doses is for perfusion headset. It saves life. Do you think we should cancel this test?
Absolutely not, the last part, number one. Secondly, the high doses are from perfusion. It is also incorrect, totally. We can, let me see if I can quickly show, but that will take time. If you can see to the second paper, which I had shown in the 3 papers, we have done analysis on which kind of patients are getting high doses and which indications are leading to this 100 millisievert cohort, and what is the frequency of those indications leading to this group. So this has been studied very, very well. So one cannot say that it is perfusion. So, and we had listed top 50 conditions. So there are more than 50 conditions are there. We listed top 50 in that paper. So there are many, many conditions, number one. Another finding was that we assumed that patients are needed recurrent imaging for follow-up of a particular disease, like oncology patients, or chronic disease like Crohn's disease. But it was not so. 50% of the recurrent imaging was not for the follow-up of the disease, but for other conditions, chest infection, trauma. So this was a very enlightening work to us also, that who are the group of patients who land up with recurrent imaging. So it was, when we did not have data, then we could point finger to, okay, this. So the brain perfusion was only for tissue reactions, 380 or so in 2009. But after that, this is not the case. Thank you.
We have a couple of questions from Dr. Hilke Frick-Bersma. I know her. She's the chair of the local organizing committee of the ETRAP 2023. It's an international conference on education and training in radiation protection. I take this opportunity to inform our audience that this year will be organized in June, end of June in Groningen. So it is related to our topic, radiation protection, education and training. So for those of you who are interested, you can join, attend the conference. So the question is, so how do we communicate or explain what we exactly mean when talking about the collective effective dose? What is it and what does it not mean, collective dose? One question is, so about how to communicate. That's what I understand from the question. How do we explain, I guess, to the patient?
Thank you for this question. At the outset, let me say that we did not talk about collective dose at all in this talk. Our talk was only cumulative dose to individual patient. Collective dose is to the population. So absolutely, we were focused on cumulative dose. So this was a totally different topic. I think I should leave it there.
Okay, thanks for the clarification, but I will again then rephrase the question. How do we explain to the patient about the doses from recurrent examinations? Well, is there any, do you think that we need to inform patients? Point number one. Point number two, how do we discuss this? How do we inform the patients?
Firstly, I will say that we people, medical physicists, are hardly ever explaining to the patients. Sometimes we extend our boundaries too much. So this is the job done by the referring physicians primarily. And they do have to explain to the patients the doses as such from individual exams also, and that is what they have been doing so far in whatever way. So there is definitely need to have better mechanism to explain to the patients, because in the past most patients will not talk about those, will not ask about those, but these days more and more patients are asking. So there is a need for creating better awareness among referring physicians who are supposed to be dealing with the patient. We have published quite a good number of papers on that, and IAEA website also, and many other organizations have. So, for example, I myself, when I have to see anything regarding my symptoms, not related with radiation, but anything, I put in the Google and I see Mayo Clinic or Cleveland Clinic, I trust that. So many organizations are providing this. So go to trustworthy organizations, and these organizations are providing information on communication with patients. There is a publication from WHO for pediatric imaging. The IAEA website, ARPO website has a huge information. In US, there is a website that by the RSNA and all that. So there are organizations which provide this information.
Thank you, Madan. We have 3 or 4 questions on the same topic. How do we calculate doses? So one question is about you. How do you calculate? How have you calculated doses in your studies, patient doses, using TLDs, using any other methods? And then there are also other questions related to dose calculation. Do you know of or can recommend any CT dosimetry software that is modern, freely available, has a large fandom library, and is easily available? And another question in the relevant question that is in the chat, solutions for tracking doses for a patient that underwent imaging on different centers in 1 year.
These are all very pertinent and good questions. Let me start with the first part about at my center. And also I heard you say about TLD and all that. TLD is something which is a passive dosimeter. I personally never like passive dosimetry. I prefer active dosimetry. So TLD may be for occupational. Even there also in our hospital, we have switched over to the active dosimetry with the wireless transmission, so that the dosimeters don't have to be sent. So whatever. So active dosimetry, number one. Number two, in our hospital, we have a dose management system like Radiometrics we have. So what I can do, I can key in the medical record number of any person, and it gives me the list of all the exams and the doses and cumulative doses obtained by that individual. How does the system estimate the dose? Is that it has a Monte Carlo estimation system for which every slice by slice, it has the factors and available. So the moment a patient is scanned, so it sees the topogram, and based on that topogram and placement, it estimates the organ doses for various organs. So it provides the organ doses, and then based on ICRP 103, it estimates the effective dose. So suppose if I want to have all patients above 100 millisievert, I just put the threshold 100. So that is all patients with above 100 millisievert will be listed. It lists that. So various dose tracking and dose management systems are providing this. And these automatic systems are the which I think are better than any other ways in the past. In the past, of course, from radiological information or PACS and all those things, there were also some freewares. I have never tried that. So I personally have used only the dose management, standard dose management systems, and I will feel that they are good. Thank you.
Thank you, Madan. There is an interesting question from an anonymous attendee. Should we follow up patients with high doses on an individual level? And if yes, how?
This is something which I will say is a very good topic for radiation researchers, that is radiation epidemiologists and biologists, that they should take these individual patients as their cohort. Gone are the time when patient dose estimation was a difficult thing and reconstructive dosimetry was used. So we are not in that era anymore. We have much, much better dosimetry available these days. And for radiation epidemiologists, it is so easy to get radiation dose information in a much more reliable manner than what it was some years ago. And medical information is also available. I am sure in the coming 10 years, there will be lots and lots of projects with millions and billions of dollars going into the analysis of these patients with high doses. And I presage that after some 10, 15 years, we may find that our knowledge on radiation effects, which is derived from studies available so far, including the Japan A-bomb survivor, we may find that our results are different. So this is a very important topic to work upon. And in future, this cohort is very important cohort and most useful for future radiation protection guidance also. Thank you.
Thank you. There are a couple of questions about CBCT in radiotherapy. About the doses from CBCT. I think you presented a slide on this. Doses from CBCT in radiotherapy.
I did not present the slide. I wanted the work to be done on this. And the issue is that the non-target doses in CBCT in radiation oncology need to be studied and added to the cumulative dose from other exams. Maybe I missed mentioning this in one of the previous questions when somebody asked about exams being performed on the patient in different hospitals. So this was one issue which was in my mind some years ago. But then I realized that we people or most patients undergo examinations within a particular healthcare facility. So even if they are undergoing some exams outside, one can ignore them for the moment till technology allows that. So including exams from the same healthcare setup is adequate. So coming back to the CBCT, yes, this is one area where we have not done work, and I am trying to motivate others to do their work. And I believe in the coming year, we will have more information on doses in the imaging in radiotherapy.
Actually, here in Europe, there are a couple of studies or more, current studies on CBCT doses in radiotherapy. From Dr. Camille van Spijbroek, would you recommend to cumulate the dose over the lifetime of the patients or over a period of years, for example, 5 years?
Lifetime.
Lifetime. There is another question about airport body scanners. I think this is not very relevant to this question, to this webinar. Doses from airport body scanners, and if it is safe for pregnant women to get through. Do you agree that analysis of cumulative doses is more of a quality control mechanism for a medical physicist rather than something that needs to be reported openly to patients? This is from an anonymous attendee.
See, patients reporting to patients is a very critical question. I will say that this is one of the misdirections also we take, many of us, when we say, oh, cumulative dose, if the patient comes to know what will happen or doctor comes to know. We are doing DRL work for decades. What is happening? We as medical physicists have access to the doses. It is not the physician who is knowing about DRL and what is the DR dose to this patient. So same way, when physicists are doing work on DRL, physicists are doing work on cumulative dose. How come the physician will know about the cumulative dose and they will get affected by that? Anyhow, coming back to the question, patient information, only if patient wants, then only one should tell. Otherwise, there is no need to proactively tell patients unless there are requirements. In the last few years, the requirements have started. It's starting from California law to the other states, and now European directive also, there is some need on that. So the needs have been putting in patients' file, not proactively telling patients. So patients have the right to ask. Those who ask, they should be provided the dose information, but not proactively. But putting in patient records is slowly picking up more and more as per requirements. So it could be done there. I think I have covered this point.
Definitely. Madan, we need another webinar perhaps to discuss more extensively this topic. Very, very interesting. And unfortunately, time flies. So we need to close this webinar. I'd like to thank you for your talk, for being here. And of course, I'd like to also thank all colleagues for their very, very active participation. Many, many questions. Unfortunately, we didn't have time to discuss all these questions. So thanks a lot again. And please keep in mind that tomorrow is the day 4 of the week with another important topic, webinar, leadership in medical physics. See you tomorrow. Bye.
Thank you.
Thank you.